Imagine a 22-year-old walks into a psychiatric ward,
Right.
and they're experiencing severe auditory hallucinations, like highly systematized paranoid delusions, just a total terrifying break from reality.
Yeah, a classic presentation.
Exactly.
Yeah.
So naturally, after a brief observation, the clinical team diagnoses them with schizophrenia.
Makes sense.
They start them on standard antipsychotics.
Yeah.
But, and here's the twist, the real cause of their psychosis isn't a primary psychiatric condition at all.
No, it's not.
The actual culprit is hiding in their liver. Or maybe it's, a tiny mutating enzyme in their cellular recycling centers.
It's a genuinely terrifying scenario.
It really is. Welcome to the Deep Dive. Today, we are completely dismantling how we think about mental illness.
Because for a certain subset of patients, that scenario you just described, that is the absolute reality.
Yeah.
We're so thoroughly trained to look at the mind, right?
Yeah.
But sometimes the mind is, well, it's just the monitor displaying an error code for a failing body.
Oh, I like that. The monitor displaying an error code. Because, we anchor every discussion here on a core principle, which is that psychiatry is the study of how brain, mind, and experience interact, and how that process can go completely wrong.
Exactly.
And usually when we talk about a medical diagnosis, there's this expectation of precision for you as a clinician. You break your arm, the x-ray shows that jagged white line, and the doctor just points to it.
Spot on, yeah. It's objective.
But you step into the world of psychiatric symptoms, like severe depression, sudden anxiety, psychosis, and that x-ray machine is essentially useless. We were looking at a really murky diagnostic landscape.
Which is exactly why we need to build robust, resilient mental models to navigate it. I mean, the diagnostic waters are muddy, so our clinical reasoning just has to be incredibly sharp.
So let's build that model for everyone listening. I want you to imagine the human brain for a second as this hyper-advanced, high-performance city.
Okay, a city. I like it.
Usually when we study psychiatric symptoms like depression or schizophrenia, we tend to view them as software bugs.
Right, like local traffic jams within the city's internal networks.
Yeah, a glitch in the routing algorithms of our thoughts and our moods.
And that is the standard classical paradigm in psychiatry. We look for the psychological software issue, or maybe a localized neural network misfiring because of a primary neurotransmitter imbalance.
But what if that's not the whole story? I mean, what if the city's municipal garbage disposal system entirely breaks down and toxic waste is just piling up in the streets?
That would cause chaos.
Right. Or what if the city's sewer treatment plant fails and toxic sludge is backing up into the water supply?
Yeah.
Or, even more fundamentally, what if the external supply chain suddenly stops delivering the essential raw materials the city actually needs to function?
If any of those systemic infrastructure failures happen, the city's highest level functions, its communication, its logic, its overall mood, they go completely haywire.
Exactly. It's a total systemic collapse mimicking a local software issue.
It's a perfect metaphor. Because those software bugs are exactly what psychiatric illnesses look like on the surface. But in this deep dive, we are looking at something entirely different.
We're looking at the hardware.
Right. We're looking at systemic hardware and supply chain failures. Specifically, we're diving deep into neurometabolic and neuroendocrine disorders. We are looking at what happens when the chemistry of the body fundamentally alters the mind.
And our mission today is sourced directly from Chapter 2.14 of Kaplan and Sadok's comprehensive textbook of psychiatry.
A fantastic resource.
It really is. But our goal here isn't just to rattle off a list of obscure rare diseases for, like, a medical trivia night.
No, definitely not.
For the clinicians, the trainees, and the registrars listening, we want to help you build mental models that clarify exactly how systemic metabolic and hormonal disruptions create perfect phenocopies of psychiatric illnesses.
And just to clarify for you, a phenocopy being a condition that presents with all the characteristic features of a primary psychiatric diagnosis, but it has a completely different underlying biological cause.
Right, it copies the phenotype.
Exactly. We need to strengthen your clinical reasoning so you can recognize these hardware failures before irreversible damage occurs to the brain.
So let's start with a foundational logical question.
Go for it.
If a patient has a severe metabolic disorder, say, a genetic defect where their cells literally cannot process energy, why on earth does that present as a psychiatric illness like schizophrenia or bipolar disorder?
It's a great question.
Because wouldn't a systemic lack of energy just cause a gross neurological catastrophe? Like, shouldn't they just be in a coma?
You would think so, yeah. And that is the logical assumption. But this is where we have to understand the concept of the psychiatric window.
The psychiatric window. Okay, break that down.
To understand this, you really have to look at the mechanics of neurodevelopment. If a fetus is born with a severe, completely absent enzyme deficiency, you're absolutely right. It causes catastrophic brain failure in infancy.
So they don't even make it to adulthood to get a psychiatric diagnosis.
Right. You see severe intellectual disability, intractable seizures, delirium, and often very early death. The basic primitive systems of the brainstem, the vital autonomic functions, they just cannot survive that profound metabolic crisis.
Okay, so the whole city powers down in that scenario.
Yeah.
But what if the defect isn't a complete blackout? What if it's like just a brownout?
That is the crucial distinction. If you have a mild or partial enzyme deficiency, perhaps due to a specific genetic mutation that leaves the enzyme working at, say, 10 or 20% capacity, the basic vegetative systems, those older, more primitive parts of the brain, are actually spared.
Oh, wow. Because they don't need as much energy.
Exactly. They can get by on that lower efficiency. Instead, the metabolic disruption slowly, insidiously damages the latest maturing, most highly synchronous networks in the brain.
And when you say late maturing networks, you're talking about the prefrontal cortex and its connections, right?
It's spot on.
The white matter tracks connecting the frontal lobes to the rest of the brain, the areas responsible for complex logic, impulse control, and reality testing.
Precisely. The cortical and subcortical networks. These specific, highly complex networks don't actually finish wiring up until adolescence and early adulthood.
Right. The teenage brain is still under construction.
Very much so. And they require massive amounts of energy and perfect chemical balance to form properly. So the subtle damage from a partial metabolic defect manifests exactly during that time period because those networks simply don't have the metabolic capital to finish construction.
And what else typically emerges during adolescence and early adulthood?
The major psychiatric illnesses.
Schizophrenia, bipolar disorder, major depressive disorder. So the metabolic damage perfectly mirrors the onset timeline of primary psychiatric diseases. That is the psychiatric window. For you listening, I mean, this fundamentally changes how we view mental health. We tend to separate the mind and the body.
We do, yeah.
But this tells us that a hidden genetic bottleneck in your metabolism might only reveal itself when your brain tries to run its most complex software in your 20s.
Yes. The metabolic area disrupts the higher-order cognitive functions because those rely on perfect, rapid synchrony across the entire brain.
Now, I can hear a clinician listening to this and thinking, wait a minute. Don't we screen babies for metabolic diseases? We do the newborn heel prick test. Shouldn't we catch this early? Long before they hit adolescence.
Yeah. That brings us to the illusion of the neonatal screen. And honestly, it provides very dangerous false assurance to clinicians.
Why is it an illusion?
Because neonatal screening only catches a tiny fraction of metabolic disorders. Literally hundreds of these disorders have been described in the literature, but in most healthcare systems, they screen for a very limited panel, often fewer than 10 or 20 core conditions.
Wait, really? So the vast majority just slip through the net entirely?
They do. Furthermore, the late onset partial variants we are talking about, the ones that present in the psychiatric window, they are almost entirely missed by these screens.
Because the levels aren't abnormal enough at birth.
Exactly. The biochemical abnormalities simply might not be severe enough at birth to trigger an alert. The baby isn't under enough metabolic stress yet. They might only decompensate later in life under the stress of puberty or a severe infection, or even just drastic dietary changes.
Okay, so if the neonatal screen won't save us, and the patient sitting in front of us looks exactly like they have a primary psychosis or severe depression, how do we spot the hardware failure?
Yeah, the million-dollar question.
How do we differentiate a phenocopy from the real thing?
This brings us to the clinical rule of atypicality. These disorders produce phenocopies that are initially indistinguishable from primary psychiatric illnesses. But the key to unlocking the true diagnosis is extreme clinical vigilance for the atypical.
The atypical.
Yes, you have to look for the subtle, weird quirks. The psychiatric symptoms are the loud alarm bell, but the atypical physical signs are the breadcrumbs leading to the actual fire.
Give us some concrete examples. What does atypical actually look like in a standard psychiatric assessment?
It's the psychiatric presentation combined with something physiological that just doesn't quite fit. For instance, a patient presenting with new-onset psychosis, but on physical examination you notice organomegaly.
Like an enlarged liver or spleen.
Right. Or they have a specific odd inability to move their eyes in a certain direction, or perhaps they have bizarre dietary quirks, like an absolute lifelong aversion to high-protein foods that they can't really explain.
Oh, that's fascinating.
Or, and this is probably the most dangerous one, they develop a severe psychiatric syndrome. You give them a standard low-dose psychiatric medication, and their neurologic status rapidly and inexplicably worsens.
Oh, wow. That is the ultimate red flag right there.
Absolutely.
Okay, so we have the conceptual framework. We know to look for atypicality in the psychiatric window. Let's move from the concept to the actual mechanisms.
Let's hear it.
Let's dive into the specific neurometabolic syndromes. And I want to start with the city's garbage disposal system, the lysosomal storage disorders.
Right. So the lysosome is a subcellular organelle, essentially functioning as the cellular recycling center. It contains hydrolytic enzymes that break down and recycle macromolecules, things like complex lipids and proteins.
And when an enzyme in this factory fails,
The garbage isn't broken down, it's that simple. Toxic byproducts accumulate inside the cell, literally ballooning the cell and eventually destroying it.
let's look at a specific one mentioned in the chapter, metachromatic leukodystrophy, or MLD. What is the specific garbage piling up here?
In MLD, there is a genetic deficiency of the enzyme aryl sulfatase A, or ASA.
Okay,
Because ASA is deficient, a fatty substance called cerebroside sulfate accumulates. Now, this specific waste product is highly toxic to myelin, the protective fatty insulation around our nerve fibers. And crucially, it has a very strong predilection for destroying frontotemporal myelination.
So the insulation on the wires connecting the frontal lobe, which is our logic center, to the temporal lobe, our sensory and language center, it just melts away.
Yes, the structural integrity of those connections degrades. And how does this manifest? Well, in the adolescent or adult onset form of MLD, up to half of these patients present with a schizophrenia-like psychosis.
Up to half. That's huge.
It is. They have auditory hallucinations, highly systematized delusions, formal thought disorder, and even catatonic posturing. On the surface, a purely clinical interview might find it completely indistinguishable from typical schizophrenia.
Here's where it gets really profound, though. You referred to these rare diseases earlier as Rosetta Stones.
I did, yeah.
What does a rare genetic garbage disposal disease like MLD tell us about run-of-the-mill primary schizophrenia?
It offers a massive biological clue.
Yeah.
Because MLD precisely disrupts late-stage frontotemporal myelination and perfectly mimics schizophrenia, it strongly implies that white matter disconnectivity, the literal failure of these specific brain regions to pass signals properly, is a core pathophysiological mechanism in primary psychosis itself.
So we aren't just looking at dopamine receptors. We are looking at the integrity of the wiring itself.
Exactly. We're looking at the cables. In fact, studies have shown that some patients diagnosed with treatment-refractory schizophrenia actually have an ASA pseudodeficiency, or intermediate levels of this enzyme.
Wait, really?
Yeah, suggesting it might be an independent risk factor for psychosis.
That is mind-blowing. The metabolic defect literally traces the anatomical blueprint of madness.
It's a map.
Okay, let's look at another garbage disposal failure. PSYCH disease, specifically the adult onset variant, also known as GM2 gangliosidosis.
PSYCH is caused by the deficiency in an enzyme called HEXA. Without HEXA, a type of lipid called a GM2 ganglioside accumulates.
Okay.
These are lipids that are supposed to be cleared from the neuronal cell membrane as part of normal cellular turnover.
And when they aren't cleared, the source text mentions something truly terrifying. It says this accumulation causes the neurons to literally mutate.
Yeah, it does.
It uses the phrase ectopic dendritogenesis. Stop right there and break that down for me.
Right.
Because ectopic means in the wrong place, right? Like an ectopic pregnancy.
Yes, ectopic means occurring in an abnormal place or position, and dendritogenesis is the creation of new dendrites. Those are the branches that neurons use to receive signals from other neurons.
So the neurons are literally mutating and sprouting new, freakish connection wires where they shouldn't be.
That is exactly what is happening. The structural damage is profound. The accumulation of these lipids causes the axon hillock.
Wait, the axon hillock, that's where the signal fires, right?
Exactly, the trigger point of the neuron. It causes it to balloon and sprout these massive abnormal branches called meganeurites. It also causes focal enlargements along the axon called spheroids.
Yeah.
The microconnectivity of the brain is completely altered. The wires are just splicing into the wrong buildings.
So the city's communication grid is structurally chaotic. What does a late-onset Tay-Sachs patient look like when they walk into a clinic?
Well, the late-onset form can present with speech disorders and gait disturbances, clumsiness, essentially. But crucially for us, 30 to 50% of these adult patients present with psychosis or severe affective disorders like acute mania or profound depression.
And there is a massive clinical trap here for the psychiatrist, right? Because if you see a manic or psychotic patient, your instinct is to give them an antipsychotic.
And that instinct can be devastating here. If you misdiagnose a late-onset Tay-Sachs patient with primary schizophrenia and prescribe them typical neuroleptics, those dopamine-blocking antipsychotics or tricyclic antidepressants, they are exquisitely sensitive to the extrapyramidal motor side effects.
Why is it so sensitive?
Because their brain's microconnectivity is already compromised by those meganeurites we talked about. Throwing a heavy neuroleptic into the system can precipitate a severe, rapid neurological decline. They can lose motor function incredibly fast.
It's like pouring thick grease onto a motherboard that's already short-circuiting.
That's a horrifying but accurate image, yeah.
So what do you do? I mean, how do you treat a psychotic patient who gets neurologically worse when you give them antipsychotics?
This is where clinical reasoning requires flexibility. For the severe psychotic illness in late-onset Tay-Sachs, electroconvulsive therapy, or ECT, has actually been shown to be effective and much safer than typical antipsychotics.
Wow. ECT to the rescue.
Okay.
Let's keep moving through the lysosomes. Niemann-Pick disease type C or NPC. What's the mechanism here?
NPC is a defect in intracellular cholesterol trafficking involving the NPC1 or NPC2 genes. Cholesterol and gangliosides accumulate in the late endosomes of the cell. But what is most fascinating and terrifying is that this disrupted cholesterol metabolism actually alters how the brain processes tau proteins and beta amyloid.
Tau and beta amyloid. That sounds exactly like Alzheimer's disease.
It is the exact same downstream pathology. These patients develop Alzheimer-like neurofibrillary tangles, but they develop them much, much earlier in life.
Oh, that's tragic.
The adult onset form frequently presents with psychosis, and this psychiatric disturbance can actually precede any noticeable motor symptoms by years.
So if they just look psychotic, what is the atypical clue? How do we spot NPC before they develop full-blown early-onset dementia?
The quintessential clinical clue, the breadcrumb we're looking for, is the co-occurrence of psychosis with vertical supranuclear ophthalmoplegia,
Which in plain English means?
a vertical gaze palsy. The patient physically cannot look upwards without tilting their entire head, or they have extreme difficulty smoothly tracking an object moving up and down.
Really? Just looking up?
Yeah. If you have a young adult presenting with new onset psychosis and during a basic cranial nerve exam you notice their eyes stall when you ask them to follow your finger toward the ceiling, you must consider Niemann-Pick type C.
And why is spotting this specific physical quirk so critical?
Because of the holy grail of neurometabolic disorders, reversibility.
Reversibility.
Yes. Unlike primary schizophrenia, NPC has targeted biological treatments. Substrate reduction therapies, like a drug called miglustat, or experimental treatments using cyclodextrin, can actually halt or even reverse the motor and cognitive deficits. By restoring the biochemical cholesterol trafficking, you can potentially clear the psychiatric disturbance entirely.
That is the ultimate goal. Reversing the irreversible. Just to briefly round out the lysosomal disorders before we move on, the chapter touches on Fabry and Gaucher diseases.
Yes, let's touch on those. Fabry disease is an X-linked disorder affecting the vascular endothelium, that's the lining of the blood vessels.
Okay.
The early signs in childhood are often excruciating, burning pain in the fingers and toes called acroparesthesias. In adulthood, up to half of all sufferers develop severe clinical depression.
Half. That's a massive proportion.
It is, and importantly, this depression seems directly linked to the burden of peripheral pain and the specific microscopic vascular damage in the brain, rather than just a psychological reaction to being chronically ill. Enzyme replacement therapy can improve these physical manifestations and thereby lift the depression.
And Gaucher disease.
Gaucher involves a deficiency in an enzyme called beta-glucocerebrosidase, coded by the GBA1 gene. What is most striking about Gaucher in modern neuroscience is that carrying even one mutated copy of the GBA1 gene is now known to be the single biggest genetic risk factor for developing Parkinson's disease.
Just one copy.
Just one. The molecular relationship between the accumulating glucocerebrosides and the deposition of alpha-synuclein, which is the hallmark of Parkinson's, is profound. For Gaucher patients, depression and anxiety are very common.
And is that reversible too?
Remarkably, yes. Intravenous enzyme replacement therapy is associated with significant improvements in mood. And what's wild is that this happens even though the large enzyme molecules themselves don't cross the blood-brain barrier effectively.
So it's just fixing the body that fixes the brain.
Exactly. It suggests that reducing the systemic metabolic burden alone can relieve psychiatric symptoms.
Okay, so we've seen what happens when the garbage trucks break down, but what if a different part of the infrastructure fails? Let's talk about the cellular refineries, the peroxisomes. The source highlights X-linked adrenoleukodystrophy, or XALD.
Right. Peroxisomes are organelles responsible for, among other things, the breakdown of very long-chain fatty acids, or VSCFAs.
Very long chains, got it.
In XALD, the transporter gene responsible for moving these specific fatty acids into the peroxisome is mutated. So these saturated VLCFAs accumulate in the blood and tissues.
Then what do?
They profoundly destabilize cell membranes, and they particularly target the brain's white matter and the cortex of the adrenal glands.
So the insulation in the brain breaks down, similar to MLD, and the adrenal glands fail. What does this dual failure look like in an adult?
The adult cerebral form has a strong predilection for neuropsychiatric presentations. But unlike MLD, which almost perfectly mimics schizophrenia, XALD predominantly presents with profound mania, affective psychosis, or severe, uncharacteristic behavioral changes.
And if we look at their brain on an MRI, what do we see?
You see a very characteristic, highly symmetrical white matter hyperintensity. It typically starts in the splenium of the corpus callosum. It's the posterior back part of the thick bridge connecting the left and right hemispheres of the brain. And the damage spreads outward from there. And clinically, because the adrenal cortex is also being destroyed by these fatty acids, these patients often present with Addison's disease adrenal insufficiency alongside their mania.
It's incredible how these specific biochemical pathways map onto such specific psychiatric symptom clusters. Now, I want to transition to a different kind of failure.
Let's do it.
If the lysosomal and peroxisomal disorders are structural damage, let's look at what I'll call the intoxication and starvation models.
I like that framing.
What happens when the infrastructure is perfectly fine, but the city's water supply is suddenly poisoned, or the food shipments completely stop? Let's start with intoxication. Acute intermittent porphyria, or AIP.
Ah, AIP. It's a phenomenally interesting disease, both medically and historically. It's an autosomal dominant defect in heme biosynthesis.
Right.
Heme is a vital component of hemoglobin, which carries oxygen in our blood, but it's also crucial for liver enzymes.
I want to spend some time here because this is the disease famously associated with the madness of King George III, right? The British monarch who lost the American colonies and then seemingly lost his mind.
Yes. Historical retrospectives strongly suggest King George III suffered from AIP, and potentially Vincent van Gogh as well.
So let's paint the picture. King George's physicians were completely baffled. One week he was an articulate, functioning monarch, and the next he was experiencing severe abdominal agony, speaking in frantic, ceaseless sentences until foam ran from his mouth, and experiencing vivid hallucinations.
And his physicians thought it was an imbalance of the humors. They blistered his skin and purged him. It was barbaric.
But what was actually happening on a cellular level?
Think of the biological assembly line for making heme. Because of the genetic defect in AIP, one of the workers on the assembly line is too slow. The pathway is blocked.
It's a bottleneck.
A massive bottleneck. When the body demands more heme, the early stages of the assembly line ramp up, but they hit that slow worker. The chemical precursors back up, specifically two compounds called porphobilinogen, or PBG, and aminolevulinic acid, or ALA.
ALA and PBG.
Right. They accumulate to massive toxic levels and spill into the bloodstream.
So how does a buildup of a chemical precursor called ALA cause a king to hallucinate and speak in frantic word salad?
This is where we connect the biochemistry directly to the psychiatric symptom. If we look at the molecular structure of ALA, it bears a striking resemblance to GABA.
Gamma-aminobutyric acid. GABA is the primary inhibitory neurotransmitter in the brain. It's essentially the brain's brake pedal. It calms everything down.
Exactly. Because ALA structurally mimics GABA, it binds to the same receptors, but it doesn't activate them properly. It actively interferes with normal GABAergic transmission.
Dams the lock.
It jams the lock. It impairs the release of real GABA from the synapses. Without that inhibitory brake pedal functioning, the excitatory networks of the brain run completely out of control. It's a state of profound neurochemical overstimulation, resulting in delirium, psychosis, and severe agitation.
But wait, King George wasn't mad all the time. He had long periods of lucidity. What triggers the assembly line to suddenly ramp up and hit that bottleneck?
Attacks are triggered by metabolic stress that requires an acute increase in heme synthesis in the liver. This can be triggered by fasting, a crash diet, menstruation in women, intercurrent infections, or drugs that induce the cytochrome P450 system in the liver.
What kind of drugs?
Historically, that included alcohol or barbiturates. Today, it could be certain antibiotics or even some psychiatric medications.
There's a huge clinical trap here for modern psychiatrists, isn't there?
A massive one. The classical clinical triad for an AIP attack is severe colicky abdominal pain, motor neuropathies, which can mimic Guillain-Barré syndrome, causing weakness in the limbs and profound psychiatric disturbance.
So the patient comes in screaming in pain, but also hallucinating.
Right, because the patient presents with wild psychiatric symptoms, extreme anxiety, and complains of excruciating abdominal pain that has no obvious surgical cause. They are very frequently misdiagnosed with a somatoform disorder, or, historically hysteria. The doctor just assumes the pain is psychosomatic, driven by their anxiety.
So how do you catch it? What's the breadcrumb?
Look at the urine. Gross elevations of urinary ALA and PBG will often cause the urine to turn amber or even a deep port wine purple when exposed to direct sunlight or left to stand.
Purple urine.
Yes. In fact, historical accounts of King George III explicitly mention his urine being a dark bluish purple during his bouts of madness.
That is just wild. A biochemical poison that mimics the brain's brake pedal and turns your urine purple. Okay, moving from intoxication to starvation, let's talk about phenylketonuria, or PKU, and maple syrup urine disease, MSUD. These involve defects in processing amino acids, the basic building blocks of proteins.
In PKU, the body lacks the enzyme required to convert the essential amino acid phenylalanine into another amino acid called tyrosine. As a result, phenylalanine builds up to toxic levels, which is damaging, but equally importantly, the brain is starved of tyrosine.
And why do we care so much about tyrosine?
Because tyrosine is the direct biochemical precursor for dopamine, norepinephrine, and epinephrine. If you don't have tyrosine, you simply cannot synthesize dopamine. And the prefrontal cortex, the area governing executive function, mood, and social behavior, is particularly exquisitely vulnerable to this dopaminergic starvation.
And what happens in MSUD?
MSUD is a defect in breaking down branched-chain amino acids, or BCAAs, like leucine, isoleucine, and valine.
Oh.
The accumulation of leucine in the blood causes massive disruptions.
How?
Well, it competes with and inhibits the transport of other essential amino acids across the blood-brain barrier. It causes a chronic, severe cerebral deficiency of valine, and the toxic keto acid derivatives of leucine literally deplete the brain of glutamate, which is a vital excitatory neurotransmitter.
So both of these diseases severely disrupt the neurochemical balance, starving the brain of either dopamine or glutamate. But we test for these at birth, don't we? This is what the heel prick test is famous for. Babies with PKU are put on very strict diets.
They are. And early, rigorous dietary control absolutely saves their intellect. They completely avoid the profound intellectual disability and severe seizures seen in historically untreated cases. But here is the tragedy of the lost adult patient.
The lost adult patient. What happens to them? They grow up, and then what?
Maintaining a highly restrictive, low phenylalanine or low BCAA diet is incredibly difficult socially, financially, and practically. When these children hit adolescence or young adulthood wanting to fit in with their peers, many abandon the diet.
Teenage rebellion.
Exactly. And because they aren't having immediate life-threatening seizures like they would have in infancy, they think they're fine. They think they've outgrown it. But the biochemical starvation slowly, quietly takes its toll.
My analogy for this is like trying to run a high-performance engine without motor oil. It doesn't explode the second you turn the key, but the friction builds. Eventually, the higher-level functions just stall out.
A very apt analogy. Years later, they present to psychiatrists with severe agoraphobia, profound, intractable depression, and total executive failure. They can't hold down a job or organize their lives. Their prefrontal cortex simply doesn't have the dopamine to run the software.
So sad. But can we fix it?
The incredibly rewarding news here is that returning to the restrictive diet, even years later in adulthood, can reverse many of these psychiatric symptoms. We can literally feed the brain the precursor it's missing and watch the severe agoraphobia lift.
That is just incredible. Okay, what about urea cycle disorders, or UCDs? If lysosomal disorders are the garbage trucks failing, the urea cycle seems like a failure of the city's sewer treatment plant.
Exactly right. The urea cycle in the liver is how the body gets rid of waste nitrogen generated from breaking down proteins. If the cycle is defective, the nitrogen isn't flushed out as urea. Instead, ammonia builds up in the blood.
And ammonia is bad news for the brain.
Very bad. Severe, complete defects cause catastrophic neonatal coma. But mild, late-onset defects cause mild to severe hyperammonemia only under specific metabolic stress.
The chapter refers to these patients as the secret vegetarians. Why?
Because ammonia is highly neurotoxic. In these mild adult cases, the patients implicitly, subconsciously learn throughout their lives that eating a large steak or a high-protein meal makes them feel terrible, lethargic, confused, agitated, or nauseous.
Or they just stop eating it.
They slowly, naturally avoid protein. They become secret vegetarians not for ethical reasons, but for sheer biological self-preservation. When they do experience a sudden spike in ammonia, say from a viral illness or a sudden high-protein binge, they present with severe agitation, visual hallucinations, and acute confusion.
There is a specific UCD mentioned, OTC deficiency, that has a really sneaky, tragic presentation in women.
Ornithine transcarbamylase, or OTC deficiency, is an X-linked disorder. Because women have two X chromosomes, heterozygous females often have enough residual enzyme activity to be completely asymptomatic for most of their lives.
So they might just be one of those secret vegetarians.
Yes. But the massive metabolic stress of pregnancy, and particularly the catabolic state of delivery and uterine involution, can completely overwhelm their compromised urea cycle.
So they present in the maternity ward days after giving birth with what looks exactly like standard postpartum psychosis.
Yes. They become delirious, agitated, and psychotic. But standard antipsychotics won't cure a hyperammonemic crisis. In fact, if you just sedate them, they could slip into an irreversible hyperammonemic coma. You have to recognize the underlying metabolic collapse, stop protein intake, and use ammonia scavengers.
Wow. Let's finish up the metabolic section with two disorders that have very strong visual clues: cerebrotendinous xanthomatosis, or CTX, and homocystinuria.
CTX is a defect in cholesterol metabolism, where a substance called cholestanol accumulates. It deposits in the brain, causing psychiatric symptoms, but crucially, it also deposits in the lenses of the eyes, causing early juvenile cataracts.
And in the tendons, right?
Yes, most classically causing massive visible swellings called xanthomas on the Achilles tendons.
So if you have a patient presenting with adult-onset depression or a treatment-resistant schizophrenia-like psychosis, and you notice giant lumps on their heel cords, and they mention having cataract surgery in their 20s, you're looking at CTX.
Precisely. The physical exam solves the psychiatric mystery. And homocystinuria is a defect in the metabolism of the amino acid homocysteine. These patients accumulate very high levels of homocysteine, which is highly toxic to blood vessels and connective tissue.
And what's the visual breadcrumb here?
They often have a marfanoid appearance, tall stature, very long limbs, arachnodactyly or spider-like fingers, and crucially, because their connective tissue is weak, they experience a downward dislocation of the optic lens.
Wait, their eye lenses literally fall out of place.
Yes, the suspensory ligaments holding the lens fail. From a psychiatric perspective, they frequently suffer from marked personality changes, severe depression, and a schizophrenia-like psychosis.
That's a lot to deal with.
It is. Interestingly, this ties into much broader psychiatric research. Less severe variants in the MTHFR gene, a key gene in the homocysteine metabolism pathway, have been shown to be an independent, measurable genetic risk factor for the development of primary psychosis in the general population.
Okay, we've covered a massive amount of ground. We've looked at the city's power grid, the garbage disposal, the refineries, the water supply, and the sewer system. The brain's cellular hardware is failing in all of those. But let's look at a completely different system. What if the hardware is perfectly fine, the cells are intact, the energy's flowing, but the hormonal signaling grid is malfunctioning?
Ah, the endocrine system.
The traffic lights are sending the wrong signals. Let's transition into the mechanisms of neuroendocrine disorders.
This is a vital distinction to make. In endocrine disorders, the central nervous system is largely structurally intact, at least initially. But the hormonal systems, which govern global energy metabolism, systemic stress responses, and cellular turnover, are sending aberrant signals that directly alter neurotransmitter function and neuronal survival.
Let's start with the thyroid. It seems to be the classic impersonator in psychiatry. Practically everyone who presents with depression gets a thyroid panel. What happens in hypothyroidism?
The clinical picture of severe advanced hypothyroidism is often called myxedema. You see profound cognitive slowing, lethargy, cold intolerance, weight gain, and severe melancholic depression. The cognitive deficits are prominent impaired working memory, drastically reduced psychomotor speed.
The textbook mentions a phenomenon called myxedema madness. What is that?
Historically, before widespread testing, that refers to the fact that a small percentage of severely hypothyroid patients develop frank psychosis, with paranoid delusions and prominent hallucinations, alongside their profound psychomotor retardation.
So what's the actual mechanism? Why does a sluggish thyroid make you depressed or psychotic?
It comes down to a direct link with serotonin. Thyroid hormone is deeply, fundamentally linked to central serotonergic transmission. If you have low systemic thyroid hormone, you have inherently low serotonergic tone in the brain.
Oh, I see.
The receptors become less responsive. This drastically lowers your biological threshold for depression and suicidal ideation.
So the obvious solution is to treat it with thyroxine, thyroid hormone replacement. But there's a catch if the patient is currently psychotic, right?
A very important clinical caveat. While thyroxine reliably reverses the depression and cognitive slowing, if you rapidly titrate the hormone replacement in a patient actively suffering from myxedema madness, you can actually temporarily worsen the psychosis.
Why? Wouldn't fixing the deficit fix the problem?
Because you are suddenly, rapidly waking up a metabolically starved brain. The sudden influx of metabolic energy into a system that has downregulated its receptors can cause severe agitation and exacerbate the delusions. It requires very careful, slow titration, often with the temporary judicious use of a low-dose antipsychotic, to manage the transition until the receptors re-regulate.
Okay, what about the opposite end of the spectrum, hyperthyroidism?
Hyperthyroidism usually presents, as you might expect, increased psychomotor activity, severe unremitting anxiety, palpitations, and sometimes full-blown mania. The metabolic engine is running dangerously hot.
But there is an atypical presentation here, particularly in older adults, that clinicians frequently miss.
Yes, it's a very sneaky presentation called apathetic hyperthyroidism. Instead of the classic hyperactive, anxious state, older adults might present with profound apathy, psychomotor retardation, depression, and severe weight loss.
It looks exactly like a classic major depressive episode.
Or even an occult malignancy, but it's entirely driven by an overactive thyroid gland exhausting the system.
Let's look at the adrenal glands. Hyperadrenalism, or Cushing's syndrome. This is an excess of cortisol. What does chronic high-dose cortisol do to the brain?
Cortisol is the body's primary stress hormone. In short, acute bursts like running from a predator, it is highly adaptive. It mobilizes glucose. But chronically excess cortisol, whether from an adrenal tumor or a pituitary adenoma, is deeply neurotoxic, specifically to the hippocampus, which is the brain's primary memory and emotion processing center.
So chronic stress hormones literally kill brain cells.
Yes. The mechanism is essentially excitotoxicity. The excess glucocorticoids overstimulate the hippocampal neurons, making them vulnerable to metabolic insults, leading to neuronal atrophy and death. The cognitive impairment seen in Cushing's syndrome correlates directly and measurably with the volume of hippocampal loss visible on an MRI.
And psychiatrically, if someone is pumped full of stress hormones, you might guess they'd be manic, agitated, or wired.
That is a very common misconception. While mania can occur, particularly when a patient is given exogenously administered steroids like prednisone for asthma or an autoimmune condition, in endogenous Cushing's syndrome, where the body is overproducing it, severe depression is by far the most common psychiatric symptom, affecting up to 70% of patients.
Why depression and not mania?
Because the hippocampus isn't just for memory, it provides negative feedback to the hypothalamic pituitary adrenal, or HPA axis, which regulates stress and mood. When the cortisol kills the hippocampal cells, that feedback loop is broken. The mood regulation circuits collapse, leading to profound treatment-resistant depression.
And what about the reverse? Hypoadrenalism or Addison's disease?
Here, the adrenal glands fail to produce enough cortisol and aldosterone. It's an insidious, slow onset of profound fatigue, anorexia, weight loss, and low blood pressure. Psychiatrically, you see apathy, depression, reduced motivation, and subtle behavioral changes.
But it can escalate to something much more dramatic.
It can. There are rare but highly dramatic presentations of catatonia and even self-mutilation. And crucially, if a patient with known or suspected Addison's disease suddenly develops delirium, visual hallucinations, or psychosis, it is a massive red flag.
An Addisonian crisis.
Yes, it often heralds an Addisonian crisis, a sudden life-threatening collapse of the endocrine system, usually triggered by an infection that requires immediate emergency medical intervention, not an antipsychotic.
There's one more adrenal condition mentioned in the text, hyperaldosteronism or Conn syndrome. Aldosterone usually manages sodium and potassium balance in the kidneys. What is the psychiatric link there?
It is a fascinating emerging link. Untreated, Conn syndrome causes severe treatment-resistant hypertension and hypokalemia low potassium. But psychiatrically, recent studies have shown a strong, independent link to generalized anxiety disorder, severe panic attacks, and obsessive-compulsive features.
Wow, OCD from a kidney hormone issue.
Right, and this is completely independent of the classic depression we see in other endocrine disorders. It suggests aldosterone pathways might play a direct role in anxiety circuitry.
Finally, let's briefly touch on carcinoid syndrome. This involves neuroendocrine tumors, usually located in the gut or the lungs.
These tumors are essentially rogue factories. They synthesize and secrete massive amounts of peripheral serotonin, among other vasoactive substances, into the bloodstream.
But hold on, peripheral serotonin in the blood tone doesn't cross the blood-brain barrier. It can't get into the brain. So how does a gut tumor secreting serotonin affect the mind?
That is the great mystery, but the clinical correlation is undeniable. While the serotonin itself doesn't cross the barrier, high peripheral serotonin in carcinoid syndrome strongly correlates with severe impulse control disorders, unpredictable aggression, and extreme irritability.
So as finding a backdoor into the brain.
It suggests that peripheral endocrine signals have complex, indirect ways of modulating central nervous system behavior. This might be through vagal nerve signaling, the gut-brain axis communicating the inflammatory state, or through inflammatory cytokines crossing the barrier and altering central neurochemistry.
So we have covered an immense amount of complex biochemical ground. What does this all mean for the clinician listening? Let's move to integration and clinical reasoning. How does a psychiatrist actually use this mountain of information in a busy everyday practice?
It provides a necessary life-saving framework for suspicion. You cannot and should not run an exhaustive $10,000 genetic panel on every single patient who presents with depression or anxiety.
Right, that's not practical.
But the clinician must adopt a high index of suspicion for patients who fall within the psychiatric window, adolescents and young adults, whose symptoms strongly resist standard evidence-based treatments, or who have paradoxical reactions like worsening with typical psychotropics.
Like the late-onset Tay-Sachs patient rapidly losing motor function on a standard dose of an antipsychotic.
Precisely. Or patients who present with those comorbid physical anomalies we discussed. The visual changes like cataracts or gaze palsy, the odd self-imposed diets, the unexplained abdominal pain alongside psychosis. You have to step back and look at the whole patient, not just their mood or their thought content.
And there's a bigger philosophical picture here, isn't there? You called these rare disorders Rosetta Stones.
They are the ultimate biological clues. These rare metabolic disorders are not just clinical curiosities meant to torture medical students during exams. Understanding how a disrupted myelin sheath in MLD causes a highly specific schizophrenia-like psychosis gives us direct, undeniable biological insight into the pathophysiology of primary schizophrenia itself.
It shows us how the machine works by showing us how it breaks.
Beautifully put. Understanding how a GBA1 mutation causes both depression and Parkinson's directly links mood regulation to the mechanics of neurodegeneration. These hardware failures teach us exactly how the city's infrastructure was designed to work in the first place.
Let's distill this down into our key takeaways for you listening. Number 1, metabolic and endocrine systems are the foundational supply chains of brain function. Without them, the software cannot run.
Number 2, disruptions in these systems frequently cause neuropsychiatric symptoms that perfectly mimic or phenocopy primary psychiatric illnesses.
Number 3, the mechanisms are vast. They range from profound energy failure and toxic waste buildup, like ammonia in urea cycle disorders or gangliosides in Tay-Sachs, to direct hormonal toxicity, like chronic cortisol, literally excitotoxically killing hippocampal cells in Cushing's syndrome.
Number 4, psychiatric symptoms are often the very first sign of systemic disease, preceding physical symptoms by years. This is particularly true during that adolescent psychiatric window when those highly synchronous, energy-hungry frontal brain networks are still maturing and wiring up.
Number 5, atypical physical symptoms, severe treatment resistance, or paradoxical neurologic worsening on standard psychiatric medications must immediately trigger a comprehensive medical workup.
And number 6, crucially, unlike primary psychiatric illnesses, which we largely manage rather than cure, many of these systemic disorders are biologically reversible if caught in time, whether through dietary restriction, substrate reduction, enzyme replacement, or hormonal correction.
All right, it is time for our learning reinforcement. We are going to run through a rapid-fire clinical reasoning quiz to test those mental models we just built. I will present a single best answer, or SBA, Scenario. I'll read the question. You, the listener, should pause the audio and commit to an answer, and then our expert will break down the rationale. Ready?
Yeah.
Question 1. A 22-year-old presents to the psychiatric emergency department with new-onset auditory hallucinations and paranoid delusions. During the physical examination, you note that the patient has an inability to look upward, exhibiting a vertical gaze palsy. What is the most likely neurometabolic diagnosis? Okay, pause the audio and think. What is the diagnosis?
The answer is Niemann-Pick disease type C, the co-occurrence of a schizophrenia-like psychosis in a young adult with vertical supranuclear ophthalmoplegia is the classic pathognomonic hallmark of NPC. Remember, this is the intracellular cholesterol trafficking defect that causes early tau tangles, and crucially, it can potentially be treated with substrate reduction therapies like miglustat.
Question 2. A 28-year-old female patient with a family history of an X-linked metabolic disorder develops sudden severe postpartum psychosis 3 days after an uncomplicated delivery. Her partner notes she has a lifelong history of avoiding high-protein foods, claiming they make her feel foggy and sick. What specific enzyme deficiency is most likely? Pause the audio. What are we looking at here?
The answer is ornithine transcarbamylase, or OTC, deficiency. This is the most common of the urea cycle disorders. Because it is X-linked, heterozygous females can be mostly asymptomatic, but they subconsciously self-select a low-protein diet to avoid mild hyperammonemia. They are the secret vegetarians. The intense metabolic and catabolic stress of childbirth triggers a severe hyperammonemic crisis, presenting clinically as postpartum psychosis or delirium.
Question 3. A 28-year-old male is diagnosed with atypical psychosis and is prescribed a typical first-generation antipsychotic medication. Within days, his neurological and motor status rapidly and severely worsens, developing profound extrapyramidal symptoms. He has a known history of Ashkenazi Jewish heritage. What is the specific mechanism of his underlying disease? Pause the audio. What is the cellular mechanism?
The answer is a HEXA enzyme deficiency, leading to the toxic accumulation of GM2 gangliosides. This is the adult-onset form of Tay-Sachs disease. The late-onset form often presents with psychosis. These patients are exquisitely, dangerously sensitive to the extrapyramidal and motor side effects of typical neuroleptics because their brains have structurally altered microconnectivity, those aberrant megnerites sprouting from the axons. ECT is often a safer treatment for their psychosis.
Question 4. A 40-year-old female presents with recurrent, severe abdominal pain that has led to multiple negative exploratory surgeries. She now presents with a new onset motor neuropathy in her legs and an acute, highly agitated psychosis. Her partner notes her symptoms drastically worsened after she began a strict fasting diet to lose weight. What specific urinalysis finding would confirm your clinical suspicion? Pause the audio. What are you looking for in the urine cup?
You are looking for urine that turns a deep amber or port wine purple when left standing in direct sunlight. The diagnosis is acute intermittent porphyria. The genetic defect in hem biosynthesis causes a massive accumulation of porphyrin precursors, PBG, and ALA. The ALA structurally mimics GABA, disrupting the brain's inhibitory networks and causing severe overstimulation. Attacks are classically triggered by metabolic stressors like fasting, menses, or P450-inducing drugs.
Question 5. A patient with severe, chronically untreated Cushing syndrome presents with significant worsening memory impairment and severe melancholic depression. An MRI of the brain is most likely to show distinct volume loss and atrophy in which specific structure due to glucocorticoid toxicity. Pause the audio. Which brain structure is shrinking?
The answer is the hippocampus. Chronic excessive circulating cortisol is profoundly neurotoxic, causing excitotoxic damage to hippocampal neurons, which mediate memory formation and provide vital negative feedback to the mood-regulating HPA axis. The degree of memory impairment and depressive severity in Cushing's directly and measurably correlates with the loss of hippocampal volume on an MRI.
Question 6. A 19-year-old tall male presents with a gradual onset of a schizophrenia-like psychosis and profound social withdrawal. Physical examination reveals a distinctly marfanoid habitus tall stature, very long limbs, and spider-like fingers. An ophthalmologic exam reveals a downward dislocation of the optic lens in both eyes. What biochemical pathway is defective? Pause the audio. What's the failing pathway?
The answer is homocysteine metabolism, leading to a diagnosis of homocystinuria. The toxic buildup of homocysteine weakens and damages connective tissue, causing the marfanoid skeletal appearance and the failure of the suspensory ligaments of the eye, leading to the ectopic lens. More importantly for psychiatry, disruptions in this specific pathway, particularly involving mutations in the MTHFR gene, are strongly linked to the biological development of psychotic disorders.
Excellent. We've built the models, we've explored the mechanisms, and we've tested the reasoning. As we wrap up this deep dive, I want to leave you with a final provocative thought. We spend so much time, billions of dollars in research, searching the physical brain for the root causes of primary schizophrenia, bipolar disorder, and severe depression. But what if the key to solving the great mysteries of these common psychiatric illnesses lies not inside the skull itself, but hidden in the liver, the gut microbiome, or the microscopic recycling centers of the rest of the body? What if the brain is simply the exquisite, fragile monitor displaying the error code for a failing bodily system? Here are the details of this episode.
Neuropsychiatry of Neurometabolic and Neuroendocrine Disorders. Byline. Chemistry in motion when metabolic and hormonal systems shape the mind. Episode description. The brain does not function in isolation. It is deeply dependent on metabolic processes and hormonal regulation systems that operate throughout the body, but exert powerful influence on cognition, mood, and behavior. This chapter explores how disturbances in these systems manifest neuropsychiatrically. In this episode, we examine how metabolic disorders, including inborn errors and acquired conditions, can alter brain function through disruptions in energy supply, toxin accumulation, or biochemical imbalance. Similarly, neuroendocrine disorders involving systems such as the hypothalamic pituitary adrenal axis influence mood, stress response, and cognition. We explore how these conditions can present with a wide range of psychiatric symptoms, including depression, anxiety, psychosis, cognitive impairment, and behavioral change. In some cases, psychiatric features may be the first or most prominent presentation. A key theme is reversibility. Unlike many primary psychiatric conditions, some neurometabolic and neuroendocrine disorders are treatable at their biological root-making recognition, critically important. This chapter reinforces a core clinical discipline: to always consider underlying systemic causes, particularly when presentations are atypical, fluctuating, or resistant to standard treatment. This chapter reinforces a core clinical discipline. Metabolic and endocrine systems play a crucial role in brain function. This chapter reinforces a core clinical discipline. Disruptions can lead to a wide range of neuropsychiatric symptoms. This chapter reinforces a core clinical discipline. Mechanisms include energy imbalance, toxin accumulation, and hormonal dysregulation. This chapter reinforces a core clinical discipline. Presentations may include mood disorders, psychosis, and cognitive changes. This chapter reinforces a core clinical discipline. Psychiatric symptoms may be the first sign of underlying systemic disease. This chapter reinforces a core clinical discipline. As some conditions are reversible with appropriate treatment. This chapter reinforces a core clinical discipline. Clinical vigilance is essential in atypical or treatment-resistant cases.